Okay. All right, so the basic big issue that you guys need to be aware of whenever we have patients with respiratory disease is that when we can't breathe properly and we are exerting more energy to do the simple action of breathing, our nutritional needs are going to be higher and our macronutrient distribution might need to be a little bit different. That macronutrient distribution, that change in those needs, all comes back to what's called respiratory quotient. Hopefully that sounds a little bit familiar. Raise your hand if that sounds familiar. Respiratory quotient. Okay. So we started talking about respiratory quotient in Diet 411 and Diet 412. And all respiratory quotient comes down to is the byproducts of metabolism of those different macronutrients. Okay. So if you think about it, whenever we metabolize glucose or carbohydrate for fuel, what we are creating is ATP and a bunch of CO2 and water. Okay. How do we get rid of CO2 and water? How do we get rid of CO2? Huh? We breathe, right? CO2 builds up in the blood because metabolism has happened in the cells. We get rid of byproducts at the capillary level. It goes back into the blood to be pushed back to the lungs, essentially, okay? So we get rid of CO2 that is created through carbohydrate metabolism by breathing. Now, we can assume that if we have a higher carbohydrate load or a higher carbohydrate intake, we're going to be producing more what? CO2, which means we need to do what more? Breathe, okay? So if we have an individual who has respiratory failure or difficulties with breathing, wouldn't it make their medical status a little bit more challenging to keep stable if we're just loading them with carbohydrates? Okay, we're loading them with carbohydrates, they're making more CO2, and they have a hard time getting rid of that CO2. Okay, so what you can see here is that carbohydrates are related to the highest respiratory quotient. They're kind of like the baseline, respiratory quotient of 1. So that just means that the more carbohydrates we consume, the higher amount of CO2. As we go lower to protein, fat, and alcohol, okay, that respiratory quotient decreases, meaning that through metabolism of protein and fat and alcohol, we produce less CO2. All right. So in theory, a lower carbohydrate, higher fat macronutrient distribution is ideal for our patients with respiratory failure or respiratory distress. Okay. Now, I invite you to look back at the pulmonary section of the formulary, one that we have always talked about. If you go to Pulmicare, we can look at the macronutrient distribution for Pulmicare. Maybe. Where's Pulmicare? Excuse me. Where is it? Okay. If you look at the list of COPD, you see high protein, Ensure Plus, which means higher protein. And then you start to see the glucernas, which we tend to relate to diabetes. Okay, if you think about it, a diabetic formula is going to be lower in what? Carbohydrates, okay? Let's see. Where's Pulmicare? Here, 140. Oops.
All right, so let's look at pulmocare. Pulmocare is designed for people with chronic obstructive pulmonary disease, cystic fibrosis, or respiratory failure, all things that we're going to talk about in the respiratory chapter. It is a high-calorie, modified carbohydrate and fat enteral formula that may help to reduce diet-induced carbon dioxide production. Wow, we've inherently talked about this a lot, and now it's coming up as to why. So, provides complete balanced nutrition, 20% of fat as MCT. What is MCT? Medium chain triglycerides. Okay, it's a type of fat. To enhance fat absorption. It also includes some antioxidants, vitamin C and E, and beta carotene. Basically, whenever we are in respiratory distress or respiratory failure, we're going to be more susceptible to an inflammatory response in oxidative stress. Okay, but then we can come look at the carbohydrate density is 1.5. So we're getting a higher calorie per meal formula because the energy demand is likely going to be higher in these patients. We're seeing a higher protein allotment and a lower carbohydrate percent of calories. Look at that fat. 55% of the calories from this formula are going to fat. So all of that really speaks to the respiratory quotient. Okay, so here's a way that we can remember the respiratory quotient for these macronutrients. Carbohydrate is just the standard. It's 1, respiratory quotient of 1, meaning the highest carbon dioxide production. Which word on here is spelled incorrectly? Protein. Okay, it should be EI, protein. However, we can replace the TEI situation, the TE situation, with an 8. Okay, protein, that can help us to remember a respiratory quotient of 0.8 for protein. Fat kind of looks like a 71 backwards. Okay, so 0.71, and then alcohol, replace the O's with 6s, and you get 0.66. Okay, do y'all like that kind of stuff? I found this on the internet. Which you can prompt AI to help you come up with mnemonic devices to remember things too. Okay, so this explains some of the nutrition recommendations that we are going to speak about today. And it all just comes back to respiratory quotient. All right. So in anatomy and physiology, you undoubtedly learned the physiology of the respiratory system, okay? Within our lungs, we have these small alveoli, which are the air sacs that expand and contract to allow for the exchange of oxygen and carbon dioxide. So we need those little pockets to be functional and able to expand and contract for those tiny little molecules to be released and taken in during respiration, okay? If we have issues with that function, then we have issues with exchanging carbon dioxide for oxygen, okay, which means that we would have carbon dioxide build up in the blood, which can lead to acid-base imbalances. We talked about that, I think, at the beginning of last semester. So all of this comes back into play. Remember, we have respiratory acidosis, respiratory alkalosis, and all of this is also related to the kidneys, bicarbonate, all of that, okay? So a big part or a big function of our, is this fun? Yeah, what's up? A big function of our respiratory system is the maintenance of acid-base balance. Okay, so that's an important thing to remember. Now, our lungs, the alveoli specifically, are responsible for secreting what's called surfactant. Think about surfactant as a lubricant within those alveoli, the little sacs. If we didn't have surfactant in there, they wouldn't be able to contract and expand. Okay. they essentially reduce surface tension. So they make those alveoli sacs work properly to be able to transfer carbon dioxide and oxygen. Without surfactant, we would have issues with that. Now, there are disease states where surfactant is not released or secreted appropriately. And not even disease states, but even in just people who haven't gone through gestation long enough, right? Because this surfactant production comes on towards the end of gestation. This is one of the key issues in preterm birth, okay? So most infants who are born before that 36-week mark-ish require some type of supplemental oxygen, and it is all because of immaturity in the respiratory system. Anybody know somebody who's gone into labor early? Okay. Do you remember something that they probably gave mom?
A steroid.
A steroid. Do you remember what that was for?
Yeah.
Yeah. So oftentimes, if mom is showing early signs of labor, she will receive a steroid injection, and that steroid injection serves to actually stimulate maturity of the infant's respiratory tract, of the lungs. So that steroid stimulates maturity of the lungs, which helps with stimulating surfactant production, okay? I can't tell you exactly how and why that happens, but it happens, okay? So that is one of the first lines of medical treatment. Whenever mom is showing signs of preterm labor, she gets a steroid injection. At the same time, they're probably also trying to stop labor. But just in case baby's born, they want to have a couple of doses of steroid. So the production of surfactant begins at 26 weeks. This is why we see viability at 26 weeks. We're starting to see, and do y'all know what viability means? Okay, viability is like the odds of an infant surviving outside of the womb are 50-50 at that point. Right now, viability is like 26 weeks. It's starting to actually creep towards 24 weeks because of advancements in the medical practices. So by 35 weeks, we expect surfactant levels to be pretty close to normal, but still infants who are born around that age are probably going to require some kind of supplemental oxygen. But surely between that 26 and 35, we don't anticipate surfactant to be adequate. And so those infants may need more invasive oxygen, like with a ventilator, and not just the nasal cannula. Okay. Now, there can be conditions where adults have issues with surfactant production. Cystic fibrosis is kind of an example of that. And essentially what happens is the alveoli can't expand and contract, and we have an issue with carbon dioxide and oxygen exchange. Okay, any questions about this? Okay. All right, so we said carbon dioxide, oxygen transfer. We said acid-base balance. And here we're seeing the function of the lungs in our immune system. So we have a lot of mucus that is secreted within the respiratory tract, particularly within the lungs, that help to stick any bad guys, any toxins, viruses, whatever that we may breathe in. So just think about the air that you're always breathing. Does it always smell good? Does it always look good? No. Unfortunately, we don't always have very nice, clean air. And we might be around people who are putting viruses and infectors into the air as they sneeze, cough, do whatever around you, right? So it's important that whenever we breathe, that air is passed into the lungs where we have that sticky substance that can attach to those bad guys. And that can prevent us from transferring that through the body and cause us to be sick. Now, do we still get sick from airborne pathogens? Yes. Okay. Did you have a question?
No, I just thought of something. So yesterday, it's kind of on topic. We had this baby that was supposed to go home,
Uh-huh.
but they're like a year old, so they've been there since they were born. But they weren't able to go home because their gases weren't right. They weren't getting enough oxygen,
Yeah.
and they weren't. I don't know. I just thought about that
Yeah.
because it was sad.
Yeah. So they could basically if they're not having appropriate carbon dioxide oxygen exchange, that could lead to acid base imbalance, which is like a big deal, especially in an infant. But I want to a very practical thing for you guys to think of when in relation to this specific function of the lungs. This is why it's so important for us to breathe through our nose and not through our mouth. Our tonsils can kind of play the part of filtering a little bit. They're not meant to do that. But if we breathe through our nose, we have little hairs in our nose that are part of this defense system. And then as air goes down into the lungs, it interacts with this immune component too. If we breathe through the mouth, we have our tonsils. They can become enlarged and infected and stuff. That's possible too. But they don't perform the same function. Okay. So breathing through our nose is actually, it's ideal. It's what we should be doing. But it comes down to like an immunological pathway too, right? So how are you supposed to be at rest? Like what's your mouth supposed to be doing? Do y'all ever think about it?
Closed.
Yeah, your mouth should be closed, okay? Your teeth should not be like clenched together, but your tongue should be suctioned to the roof of your mouth, okay? Not laying down at the bottom of your mouth, okay? So just do that for a second. Are y'all feeling your tongue suction? So when your tongue suctions to the roof of your mouth, your palate, it actually like pulls your palate down and allows your airway to open up more so that you can get more air in the proper way. And your air can be filtered through the lungs a lot better. Okay. So just something to think about. I did not have proper resting mouth posture for my entire life. That was something I learned whenever Miles was going through all of his tongue tie stuff. I could not suction my tongue to the roof of my mouth. I couldn't do it until I had my tongue tie released. So it could be a sign that you have a tongue tie if you're not able to do it. Okay. So how we determine if somebody has adequate pulmonary function, basically we can use a stethoscope and we can hear what the lungs are working. You are not going to be trained in this, but doctors, respiratory therapists, nurses are. You can hear crackling or other types of sounds that are abnormal whenever we breathe. So that's why when you go to the doctor, they ask you to like take a deep breath and exhale, and they're putting their stethoscope on your back and right here. Okay, what they're doing is listening to your lungs. Do your lungs sound good? Especially if you have like an upper respiratory infection, a cold, the flu, or something like that. They want to make sure that your lungs are acting normally and that this hasn't progressed to pneumonia or like a bronchitis type of thing. Okay. We might actually be able to listen to, let's see. Miss Sloan had bronchitis recently, and they told her, like, as soon as they listened to her breathe, they're like, oh, this is bronchitis. So let's see. That's normal. You can think of this as like wetness. So that's why you'll see it in like CF and pneumonia patients. You can even hear it, like whenever my kids have had like just a wet cough, like infection, upper respiratory infection, you can hear that without a stethoscope. Person's about to die. Yeah, okay, that was cool. I'm going to. I really just. Strider is not good. Like, they're not well. Y'all like checking your resting mouth posture now? Or are y'all not a freak? Okay. All right, so throwing it back to acid-base balance. This is the normal ranges, which we should see. So we're looking at oxygen, carbon dioxide, the pH, oxygen saturation, and bicarbonate. Okay, so all of these things can help us to determine if a person has respiratory alkalosis, acidosis. If you want to look back on this, you can go back to the acid-base balance chapter. I'm not going to test you on identifying respiratory or acidosis or alkalosis in this chapter. So you don't have to worry about that. But if you want a refresher, you can go back to that chapter. Okay, so the big important thing that you guys need to recognize and be aware of is that when people have respiratory problems or diseases, they are very likely to experience some form of malnutrition. And that is because when we have difficulty breathing, it's very difficult for us to coordinate breathing with eating and drinking. Okay. A lot of the medications as well that somebody might be prescribed to enhance breathing, such as steroids, can affect a person's taste and appetite. Okay. It's very, very common for someone to have a breathing treatment and then have the bad taste in their mouth and they don't want to eat. That is a very practical solution for a patient. If they complain of that, you can help them figure out like how often do they need to have breathing treatments and how can you plan your eating to be maximized around your breathing treatments, right? And not like immediately following. That's just like a little thing that I've learned in practice. Okay, if we can't fully inhale and exhale, that eventually starts this degradation of muscle that are needed to be coordinating breath and respiration. So with that, we can see loss of lean body mass, which also contributes to malnutrition. All of that to say, when we have a difficult time breathing, we expend more energy trying to breathe, okay? And that is coupled with us not wanting to eat or drink as much. And so this is why you can see the snowball effect where malnutrition can be present with respiratory conditions. So we need to be very careful with checking nutrition status with these patients, especially if their chronic condition has turned into some type of acute infection, okay, where we see even enhanced inflammation, oxidative stress, and the need for specific individualized nutrition. Okay, so any questions about the background? Do we feel better about it? Okay. All right, so asthma is one of our first conditions. What you need to know about asthma is this is like an IgE mediated issue, so it's immune modulated. We typically see asthma in children and they often grow out of it as they reach adulthood, but it is a leading cause of hospitalization in children. So it's a significant issue. It can be triggered by seasonal allergies. If you were a person with asthma right now, you would be struggling just with all the pollen that is around. It can be caused by stress, exercise, anxiety. So things that are just like increasing the heart rate essentially. And because this is an immune mediated condition, we also see a higher incidence of food allergies in children with asthma. So that's a common co-occurrence. Okay, so basically what is happening with asthma is that the bronchi and the bronchioles that are responsible for contracting and allowing for air exchange to happen, they become edematous and they can't contract and open up like they are meant to. So this can result in a partially obstructed airway, and this is just showing you the difference. See how this one's nice and open. This one is inflamed and edematous, and so where the air can actually pass through is much smaller. And as a result, the body is trying to like overcompensate essentially, and more mucus is produced in asthma. So we have a smaller airway for air to pass, but we also have more mucus. Okay. So we can see wheezing, increased respiratory rate, which means that the person is breathing more rapidly. The heart rate increases and we see hypoxia, basically, so less oxygen in the blood. This can result in respiratory alkalosis and can progress to respiratory acidosis. So typically, a child with asthma is prescribed a bronchodilator or an inhaler, which is essentially a steroid. And the steroid works to open up, expand those bronchioles so that air can pass through them. Because really the big issue with asthma is that the airway is constricted. So the steroid opens it up, air is able to pass through, and the person feels a lot better. Breathing can slow down. So that is the big medical treatment for asthma. Otherwise, what we can do is we can tell kids to avoid allergies as best as they can or triggers as best as they can. Maybe they take like a allergy medicine routinely during peak season, like right now. And then moderating physical activity, possibly, which you could see the negative aspect of that. Yeah.
Something that I found out as when I did get treated for my asthma with my heart rate. Once we started treatment and it is regular, my resting heart rate decreased. When I was younger,
Yeah.
I always had a fast heartbeat, but I also didn't know I couldn't breathe.
Yeah, that makes sense.
So then once we did my treatments and like over the year, I've been like decreasing the amount because I've been doing better.
Right.
But it was like something I noticed was my heart rate regularly.
Right. That makes sense. Children might, in severe cases, they might be prescribed a corticosteroid, which is a type of steroid that they take every day. It's not inhaled. It's like a medication. And a side effect of that is weight gain. So it could contribute to excessive weight in early childhood, which has its own set of challenges. So as dietitians, you could see, if you were like working at a respiratory type of clinic, you could see children with this type of condition, helping them and the parents navigate weight management while they're on a corticosteroid. Steroids in general can increase, they increase gluconeogenesis, and they often increase appetite. So that's kind of how it's working to specifically add adiposity, okay? Because if you have good regulation of glucose, like you're metabolizing glucose fine and it's available, but you're taking a corticosteroid, it's still pushing glucose into the blood by degrading other substrates. So like you have normal glucose, but if you take a corticosteroid, it actually increases blood sugar, which then creates adipose, right? And at the same time increases appetite. Okay. All right, so some of the research that we see in regards to asthma supports a Mediterranean style eating pattern. Go figure. If you get a test question on the RD exam and it asks you like which eating pattern is best for this search situation and you don't know the answer, and Mediterranean diet is one of the choices, you should pick Mediterranean diet. Okay. Unless you know for sure like the therapeutic lifestyle changes, low sodium, hypertension, right? Okay, and the reason for this is that the Mediterranean eating pattern is high in antioxidants. This reduces oxidative stress. It has lots of anti-inflammatory micronutrients, which helps with the inflammation that we often see in the respiratory system when somebody has asthma. It has a higher fiber allotment, which helps with the gut microbiome. Whenever we have higher fiber intake, we see higher short chain fatty acid production in these large intestines, which helps with inflammatory response and it feeds the gut bacteria. And in general, the Mediterranean diet is associated with like lower, more nutrient dense calories, which helps with metabolism and can improve weight maintenance, insulin sensitivity, especially in patients who are on a corticosteroid. Okay. We also see that leukotrienes and increasing the omega-3 to omega-6 fatty acid ratio can be helpful. And all of that is inflammatory related. Okay. Again, some of these patients may be on medications. Those medications may have drug nutrient interactions. Corticosteroids may encourage weight gain, which ultimately can be problematic for a patient who already has respiratory distress. And that isn't just for asthma, it's not just for children, it's for people across the board. The heavier we are, the more weight we have in the chest, and the more work that the lungs have to do to inhale and exhale. If we already have a respiratory condition and we have more weight for the lungs to work on, you could see how that could be a challenge. This is one of the reasons why in the height of the COVID pandemic, patients were turned supine in the critical care unit. So they were laid on their belly because then the lungs didn't have to inhale and exhale with the weights on top of them. Okay, does that make sense? Okay, any questions about asthma? Feel good? Okay. All right, this one is called bronchopulmonary dysplasia or BPD, bronchopulmonary dysplasia. This is a chronic lung condition. We often see it in infancy. And what it can cause is inflammation within the lungs, which can ultimately impair growth and affect how well the alveoli themselves develop. And if you remember, the alveoli is really important for the surfactant, which means that ultimately have an issue with like constriction, dilation, exchange of oxygen and carbon dioxide. So we understand that there's some genetic predisposition associated with BPD, but a lot goes into a person actually having it. So, most babies who develop BPD are born before 30 to 32 weeks gestation and weigh less than 2 pounds. So oftentimes it's related to preterm birth, which we did discuss earlier. So how infants are treated is first, we try to push off delivery as long as possible, okay? So mom might be put on bed rest, she might be placed in the hospital under close medical observation. Actually, I know my sister-in-law's sister-in-law, so my sister-in-law's husband, his brother's wife is in the hospital, and she's been in the hospital for like 4 weeks because I think she was like 30 weeks. She started, it's her third pregnancy, and she started, I can't remember if her blood pressure was high or she just started having like contractions, but for whatever reason, she was going into preterm labor. And she has to stay at the hospital now until it's a safer time for delivery, if they can continue to push labor off. But part of that is to reduce the risk of BPD in these babies. Okay, so they would push off birth as long as possible, provide the steroids to mature the respiratory tract, and then ultimately, once baby is born, mechanical ventilation is going to be required. Again, we're talking about a very early term baby, but also they've got this this diagnosis. So their medical interventions are also going to include bronchodilators, so some type of steroids to cause dilation of the bronchiole to allow more air to come in. They'll be provided antioxidants because with BPD, we see this inflammatory oxidative stress issue. And then because they're born early, they're going to be, or they're going to undergo PT and OT alongside to help with motor development. All right. So for us, what we need to do is make sure that they are gaining weight and length appropriately according to their gestational age. So dietitians who are working with these babies would be using growth charts to assess their growth and development. And a general rule of thumb is that we prescribe about 110 to 130 calories per kilogram per day for babies that have BPD. So this is a higher calorie allotment, which not only is helpful for the preterm aspect because baby has some catch-up growth to do, but also for the BPD aspect, the respiratory distress that increases energy demand. So where are those calories going to come from? Okay, babies already need the majority of their calories from fat for brain development. So very large emphasis on fat because we have a high calorie, small stomach, okay? Their energy needs are about 15 to 20% higher. They may need up to 150 calories per kilogram per day in some situations. And then looking at protein, 3.5 to 4.5-ish. So I see there's kind of like, oh, okay, sorry. This is for preterm infants, 110 to 130. And then this is for BPD infants, okay? So preterm, they have higher needs for the catch-up growth. And then with BPD, even higher needs because of the respiratory element, okay? Sorry, that wasn't clear. Does anyone remember what the vitamin D needs are for a baby? If you had to guess.
800.
You're close.
600.
600, okay? Breastfed infants, exclusively breastfed infants need 600 IU supplemented daily. Babies who are formula fed at least 1 liter per day, formula is fortified with vitamin D, so they don't need supplementation. Breast milk tends to be inadequate in vitamin D because mom's vitamin D status is typically insufficient. So we can look at this and compare the vitamin D needs for a baby with BPD, they're higher. Okay. Okay, so we would be looking at 2 to 3 milligrams per kilogram per day of iron. Iron towards the end of the gestational period is really critical. Iron is also needed for oxygen transport throughout the tissues. Okay, iron and hemoglobin. So high iron, high vitamin D, and then we would just be closely looking at their growth development to make sure calories are sufficient to support that. Anyone interested in working with babies? Yeah. Definitely. They gonna have any job openings soon? Like after your internship?
Maybe.
Yeah.
There's one opening in September, that's for sure.
Oh, yeah. For a dietitian?
Mhm.
Yeah. Maybe they'll keep it open for you.
Cause I've been going on maternity leave.
Oh, okay.
But she's trying to get another dietitian soon, because it's kind of a lot.
Yeah, I bet it is. Well, you're definitely in a good place to walk into that. So keep them liking you. Okay, so because of the nature of the corticosteroids, which increase fluid retention, which is another reason that they can cause weight gain, babies who have BPD and are on all of this medical treatment, they may require a fluid or sodium restriction. Okay, so that's one thing to consider. We don't want to cause so much fluid overload that it is also making it more difficult to breathe, because that's one thing we talked about with CHF patients, right? If they have this pulmonary edema or overload of fluid, it makes it more difficult for them to breathe. Once they are diuresed, breathing becomes easier. Okay. Breast milk is so helpful for babies who are preterm. Our preterm infants need breast milk. Okay, it is so helpful. Not only from the nutritive perspective, but also because of the risk of something called necrotizing enterocolitis, or NEC. Okay, particularly with preterm infants. So if you ever listen to the radio, I don't really hear it so much anymore, but there used to be this really long class action lawsuit commercial that you would hear about necrotizing enterocolitis in infant formulas in preterm babies. Because what we learned is that the risk of NEC was much higher for preterm babies who received infant formula. There's a lot of reasons for that, okay? It pretty much all boils down to the maturity of the digestive tract, okay? But necrotizing enterocolitis is like, it's not a good prognosis for infants. And so we know that for preterm babies, breast milk is like the first line of defense for preventing NEC. Michaela, you can probably speak on that some.
Yeah, we had a baby pass away from it, a few weeks ago.
Yeah.
But, we do have donor milk, so if mom can't
Yes.
produce breast milk, they can be put on donor milk, I think it's like 35 weeks, maybe. Yeah. Great.
Which is, yeah, they probably are just trying to get them to like
Yeah.
closer to the 36, 37 full term mark. So yes, as interns, if you're at Nichols, I believe you get a rotation at the milk bank. They used to, I don't know if they still do. But that's I think Ochsner Milk Bank, if I'm correct. So they rely on breast milk donations to feed preterm infants. Like, we have such strong research that we've created this system to get breast milk to preterm infants. So just to speak on that a little bit, the process for preparing breast milk, donor breast milk for preterm infants is very lengthy. If I wanted to donate breast milk, I would have to do like a medical questionnaire type of thing. I would have to report like medications that I'm taking, if they even allow any, because some can pass into breast milk. But if I'm accepted to donate breast milk, the milk that I donate gets pasteurized, it gets tested for pathogens or whatever. And then also it undergoes a nutrient analysis. So the people who are working in the milk bank know the macronutrient distribution, the calorie content of all the breast milk, and they can mix breast milk, they can add fortifiers to make sure that what the dietitian prescribes for the baby is exactly what baby is getting. So it's very, very cool. And all of that is done in a sterile environment, just like a TPN or something would be formulated. So yeah, I hope that y'all get to have that experience. Very cool. If you want to read more, this is a good article about infants with BPD. What time are we at? What?
9:56.
9:56. Okay. All right. Any questions about BPD? Okay, cool. So let's look at COPD, chronic obstructive pulmonary disease. You are going to see this so much. Okay, so much. This is very closely related to chronic bronchitis and emphysema. Okay. With COPD, we know that the primary risk factor is smoking. So this is a long-term consequence of chronic smoking, right? Potentially, maybe we won't see this as much. I think in general, smoking is decreasing. Do you agree with that? Maybe I like frequent places where smoking is not allowed. Like I'm always here where you can't smoke on campus. I don't know. Do y'all feel like you know people, a lot of people who smoke? I feel like it was a lot more common previously. And it's
I
not
like
just-
cigarettes, like that, we're like the vape generation.
Yeah.
I feel like people don't even vape as much.
No, they do.
They do?
They definitely do.
Yeah.
Cause that's allowed a lot of places that smoking isn't, cause
Right.
it's not like.
Well, and it'll be
Yeah.
interesting to see the long-term consequences of vaping. Like, are we gonna see the same connection with COPD and vaping as we do with smoking? I would think probably so, just because of the other respiratory types of illnesses that we're seeing associated with vaping. Do you agree that vaping was marketed as like a healthier smoking option? Yeah.
That's what it was supposed to be, and then people saw market
Yeah.
for it, and
Well, then they had like flavors and, you know, that was a big driver in
it's
younger
more
people
appealing
doing
than
it.
smoking,
Right,
Cause it doesn't stink
right.
or taste.
Yeah.
So then and then they marketed it like with like pretty colors and everything.
Right,
So that really got the teenagers into it.
right.
And then people are stuck with it.
Yeah, that's very unfortunate. So it'll be interesting to see. I mean, most of our textbooks don't really identify vaping as a contributor. So it'll be interesting over the years as textbooks are edited, will vaping come into it? Okay, so even if you don't smoke, air pollution, secondhand smoke exposure, contributes, as well as childhood respiratory infections and occupational exposure to certain industrial pollutants. So just think about like all the people who work in plants, refineries with chemicals, all of that. I think about my husband all the time, talking about respiratory things, because he's like dealing with oil and gas and chemicals that take acid off of stuff. Like it's just crazy. So all of that can contribute, and the chronic bronchitis emphysema also contributes to COPD. With emphysema, we see this play of inflammation a lot. We see it with a lot of respiratory conditions, but with especially with emphysema. In general, basically what we're seeing is that people are not able to breathe adequately, and part of that leads to this inflammatory oxidative distress. So with chronic bronchitis, we see this edematous muscle of the bronchioles, okay, which decreases the airway. And similar to what we saw with asthma, we see this coincide with an increase in mucus production, right? So basically, it just makes it a lot difficult for us to get adequate air exchange, okay? Because of that, common, and when this is chronic, right, this is chronic bronchitis. Because of that, we see these people develop some physical signs. So oftentimes their fingernails, their nail beds are gonna be cyanotic. What does cyanotic mean? Blue, okay? Make sure you know that, cyanotic is blue. But we also see what's called clubbing of the fingers, which is what you're seeing here. You see how they're like round? They're kind of like ET. Clubbing of fingers is ET. Right? That is an oxygen deprivation sign. Okay. So you will see this in patients. You'll do your physical assessment and you're going to notice that clubbing. Okay. And that is often going to align with the patient who has COPD. Another major sign of chronic bronchitis, emphysema, COPD is enlargement of the right ventricle, which we talked about in CHF, okay? When this right ventricle is too big, like this right here, the muscle atrophies and isn't able to push blood out through the aorta effectively. If blood can't push out into through the aorta, then less blood is being sent to the peripheral body, which means less oxygen. Okay. So that condition is called cor pulmonale, where we see increased size of the right ventricle. And that contributes to heart failure associated with COPD, right? So very, very common that you see these two conditions in one patient because they contribute to one another, okay? So think if we have this patient who's had COPD, it hasn't been well controlled, they develop cor pulmonale, which leads to heart failure, and now they have an issue with this edema, pulmonary edema, because of the heart failure, which means we're more likely to have fluid in the chest and make breathing even more difficult, okay? So this is where a low sodium fluid restricted diet would come into play for a respiratory patient, okay? So treating a patient with fluid overload because of the cor pulmonale COPD would also include diuresis probably and a sodium fluid restricted eating pattern, at least for the time being. My allergies are so bad. In Memphis, you could see a coat of pollen on everything. Like it was worse than it is here. And I'm not okay from it. I never take allergy medicine and I've been taking it since Sunday. Like I can't even wear my contacts because my eyes are so puffy. An aside. All right, emphysema. So with emphysema, we actually see a destruction of lung tissue that is all related to decreased surfactant, which means they can't expand, okay? Loss of surface area, the bronchioles start to collapse, and that means we can't get air in, okay? So think of emphysema as you're feeling like you're kind of suffocating. Like that's essentially what's happening. They literally can't get full breath in. A person with emphysema is likely going to need constant flow of oxygen through nasal cannula. So these might be the people that you see out and about with like an oxygen tank, emphysema. Because of the problems with breathing, we often see these people develop what's called barrel chest. Like, that's kind of a good example. I don't know if that's really, you see, it's, if you look at the sternum really, okay, you see how the sternum is coming out instead of here, it's almost concave in some people. That's sort of what we're seeing with a barrel chest. Okay. That's a common sign of emphysema. So let's add this into here. All right. So think if you can't breathe properly, if you feel like you're suffocating all the time, like you're gonna have a lot of fatigue. We're obviously not getting good oxygen saturation. So we want to work on lifestyle changes, particularly focusing on stopping smoking. You will be shocked to know how many people are not stopping smoking, even when we have emphysema, COPD, right? And that's just something we have to accept, and we have to continue to encourage those individuals to stop smoking and to adopt other lifestyle changes that can be supportive. Okay. So they're likely going to be on steroids, bronchodilators, again, that can promote this fluid retention that we have to navigate as dietitians. And then just avoiding other pollutants, environmental pollutants that can make breathing more challenging. So in general, with COPD, malnutrition is very, very common, okay? Breathing is more difficult, nutrition demand is higher for macro and micronutrients. And so we have to keep a close eye on these patients through a good nutrition assessment that includes a nutrition-focused physical exam. We understand that their energy needs are going to be about 125 to 150% of the average patient. So needs are higher. Look at those protein needs. Significantly higher, okay? Part of that is to help maintain the lean body mass that is lost through restricted breathing, okay? We generally see 25 to 30 calories per kilogram is appropriate, with about 20% coming from protein to support weight maintenance and adequate protein intake. So with these patients, it can be helpful to do small, frequent meals, especially if breathing is a challenge, and high calorie, nutrient dense meals as we do that. So for COPD patients, 5 meals throughout the day that are high calorie, high in protein. Sometimes we might have this fluid and sodium consideration that we have to think about. But in general, nutrition supplements can be helpful for patients with COPD. They can drink something that gives them a good bit of calories and protein. And that can count as a meal. Okay, which is what I was just saying. So with patients with COPD, we also want to really make sure we're getting adequate calcium, vitamin D, and other antioxidants. What time is it? Okay. I think I'll leave it there for now, because we've done quite a bit today. Okay, any questions about COPD? We'll finish this Thursday. So we'll do cystic fibrosis, pneumonia, respiratory failure, and transplants on Thursday. Okay, that feel better? Cool, okay. So we can take our break. Oh.